All right, so my topic this morning is indications for treatment of unruptured aneurysms. And I have a couple of conflicts. And really, the whole, like everything we treat, it's natural history versus the treatment risk. And that's the whole thing, the whole talk right there. But of course, it's more complicated than that because we really don't know what the natural history is. And we really don't have that great a handle on what our treatment risks are either. So it becomes a little bit more of a problem and a longer talk. So I'm just going to run through a fair number of things, epidemiology, things to consider when you're looking at aneurysms, thinking about an individual patient, things that play into the decision making. And I've borrowed very heavily for this talk from the American Heart Association treatment guidelines for for unruptured intracranial aneurysms. That was published in 2015, so it's pretty current. And it's actually a really pretty good document, and a lot of great references in there. Recommend it to you if you're looking for, what are you trying to direct? Recommend it to you if you need just sort of a reference or a review. So the epidemiology depends on what you define as an aneurysm and how you identify it, postmortem, MR scans defining the size of it, angio versus MR, but a fairly middle of the park number is about 3.2% if you base it on a population that has an average age of 50. Of course, the number increases with age, but roughly 3.2% of people out there are walking around with an intracranial aneurysm, whether they know it or not. And about 1 in 400 of those aneurysms, on average, will go on to rupture. Remember, you're including very small aneurysms, 2 millimeter, 3 millimeter aneurysms, cavernous aneurysms. So that's kind of, ballpark number that are going to go on to rupture, assuming that the rupture is a random event and that these aneurysms are prevalent and then rupture at random time points. A nice natural history study that came out relatively recently out of Norway. They got 1,006 patients to volunteer to be screened with MRA, and they found an aneurysm prevalence of 1.9% just in this random selection of people that they screened. And the thing about Scandinavian countries, Norway, Sweden, is that they have a very fixed healthcare system, so they know everybody, they know the number of subarachnoid hemorrhages that occur, and they're able to work backwards and sort of get an incidence rate from that. So they had 16.4 per 100,000 subarachnoid hemorrhages per year. They figured out from the MR scans that the prevalence was roughly 2%, and that works out to about 0.9% per year of the aneurysms rupturing in Norway. And that's probably more relevant if you're Norwegian. Overall, the sort of worldwide number that is thrown out there is about 9 patients per 100,000 will experience a subarachnoid hemorrhage, but there really does seem to be pretty wide variation from one population to another. And Japan, being one of the higher rates of rupture per aneurysm, is about 22, 23 almost per 100,000 subarachnoid hemorrhages a year. Finland's up there right around 20 per 100,000. I don't know if Norway's the same, or if they're different from Finland or not, but in Central and South America, there seems to be a much lower rate of aneurysmal hemorrhage. In North America, we're probably somewhere right around that average of 9 per 100,000. There's a whole laundry list of conditions that are associated with aneurysms, and certainly you should think about these and the increased risk of aneurysm. Polycystic kidney disease, of course, being the primary one that we see probably most frequently. These Ehlers-Danlos, Marfan syndrome, coarctation of the aorta, and then it's a fairly long list of some obvious things: neurofibromatosis type 1, and arteriovenous malformations. I was surprised recently with an article that I saw on aortic aneurysms, and I didn't really know there was a very strong association with that, but there was a pretty good paper came out recently, I forget just where it was, but suggested there's about a 10% incidence of intracranial aneurysms in patients that have aortic aneurysms. So that was a surprisingly high number for me. Familial aneurysms depends on what you define as familial. Most aneurysms, of course, are sporadic, but depending how you define familial, about 7 to 20% of aneurysms run in families. And if you look at families with more than one family member that have an aneurysm and you screen their first-degree relatives, you'll find aneurysms somewhere 9 to 19% if there's already 2 people in the family that have an aneurysm. So pretty high yield in screening families when there's more than one family member that has an aneurysm. Looking at factors that influence this and actually influence the prevalence of aneurysms in these familial patients, smoking is kind of variably reported. Hypertension seems to play a role. A nice study, again, out of Finland found that antihypertensive use was more common in patients with unruptured aneurysms, whereas patients with ruptured aneurysms were less likely to be treated with their antihypertensive agents. So there seems to be a role for hypertension, which is quite variably reported in different studies. Alcohol abuse, fairly heavy use of alcohol, also appears to be implicated in some studies in the development of aneurysms. And in multiple aneurysms also linked to more likely to occur even within the familial aneurysms in females and smokers, as I said, hypertensives, and possibly if there's a family history of cardiovascular disease. What about aneurysm growth? Certainly we worry about follow aneurysms, look to see if they're growing. Again, the growth of the aneurysm seems to be linked, again, female sex, smoking, patients who have aneurysms that start at younger age, alcohol again, and multiple aneurysms. Patients with multiple aneurysms are more likely to grow. And as we'll come to later, we'll see that there are some good studies showing, not surprisingly, that growth of aneurysms is linked to future hemorrhage. So predicting aneurysm rupture, that's the name of the game, is identifying the aneurysms that might bleed in the future. And size is really the #1 correlation in virtually every study. Size correlates best with the frequency of hemorrhage. Prior subarachnoid hemorrhage is important and increases the number, particularly for small aneurysms, if, the potential for future hemorrhage. Less consistently reported younger age, smoking, and the aneurysm morphology, but that clearly plays a role as well. Hypertension and family history of subarachnoid hemorrhage, again, linked but not as strongly. Inflammation is something that there's a lot more interest in, and there are studies that suggest that patients who take aspirin, anti-inflammatory of course, have lower hemorrhage rates than patients not taking aspirin, and it's believed to be linked or speculated to inflammation in the wall of the aneurysms. We certainly used to worry a lot about patients with small aneurysms, incidental aneurysms, whether they could take aspirin if they had, other cardiovascular risk factors. It probably seems like that's actually not a bad idea now, although it's something that was, we clearly used to contraindicate for patients with aneurysms. But that's still being worked out, and not the relationship is not well understood yet. What about the mode of presentation as a risk for future hemorrhage? Headaches, that's the most common presentation for most of the incidental aneurysms. And surprisingly, it's not really well studied, but there really isn't any known correlation with headaches or and increased hemorrhage risk. Symptomatic presentation. Wermer in his study reported a 4-fold increase for patients that present symptomatically in terms of future hemorrhage. That's really not surprising. I think probably most symptomatic aneurysms are going to be larger aneurysms, so there's a connection there, but just the fact that they're symptomatic seems to be independently associated with future rupture. Prior hemorrhage, as I've mentioned, the ISUIA International Study on Ruptured Intracranial Aneurysms, I'm assuming that's known to all of you, reported a higher rate of rupture from incidental aneurysms only if the aneurysm was less than 7 millimeters. So in small aneurysms, they broke that out and it seemed to make a difference, but as the aneurysms got larger, that didn't seem to play a significant role in the future hemorrhage risk. I've already mentioned symptomatic aneurysms, cranial nerve palsies. They seem to, more of them seem to recover with clipping, a higher percentage of them than coiling, but the complete recoveries actually happen more often in the coiling than in the clip patients. I don't know why that slide was in there. It snuck in from another presentation, I think. Ischemic presentations, patients presenting with stroke or TIAs, not clearly a risk factor or indicator for treatment unless the aneurysm is partially thrombosed. So generally speaking, if you see an aneurysm that has no partial thrombosis in it, downstream territory, a symptom of TIA or an actual stroke, generally speaking, it's not really thought that the aneurysm is implicated unless it's one of these larger aneurysms that actually has thrombus associated with it. So in treating these, you need to be thinking about modifiable risk factors, particularly for patients you're following that you're not going to intervene on surgically or to actually treat the aneurysm. Obviously, smoking is a modifiable risk factor, hypertension, and possibly alcohol, particularly if it's heavy alcohol use, patients should be counseled on. Genetic syndromes, you need to be paying more attention, screening them, following them more closely, finding out about family members. And then in the familial, the National Institute of Neurological Diseases and Stroke familial intracranial aneurysm study found that screening family members had a 19% yield of first-degree relatives. If you do have a familial patient, you should be talking to them about talking to their brothers and sisters, children. And again, in that study found that the yield was higher in the females and the smokers and the patients that had hypertension for a longer period of time. What about patients who the relatives of an isolated or single patient with a subarachnoid hemorrhage? The number of aneurysms probably is slightly higher than the general population. So we said about a 3.2% in the general population. It's probably a little bit higher, around 4% in relatives of patients of sporadic aneurysm rupture patients. But generally speaking, that isn't considered to be a significant enough difference to justify screening of families for sporadic aneurysm patients. So the general recommendation is screening for patients when there's more than one family member, and of course the syndromic patients as well. Trying to look a little bit now at the rupture rates, the cumulative predicting future rupture rates. The ISUIA again is you can't talk about this topic without mentioning it, even though it's a horribly flawed study, and I have no idea why it gets the credibility it does. I mean, the problem is just the selection bias of patients that were enrolled, and it's the patients were, in the retrospective arm in particular, were all patients who by definition had to have survived, had to have never had a subarachnoid hemorrhage, so they were aneurysms that were followed and stable and then included. But even the prospective arm were aneurysms that were selected for non-treatment, and some of the aneurysms ultimately did go on to be treated, but most of the aneurysms in that trial were ones that experienced surgeons had looked at and said they thought they should be followed rather than operated on. And in fact, just to get at that, they apparently were surprised to find that none of the cavernous carotid artery aneurysms, and there were 210 in there, went on to hemorrhage. So, that figured into their statistics where they're suggesting that the anterior circulation aneurysms don't bleed. In the small aneurysms, and this 7 millimeter odd number that was chosen came from their analysis after they saw where the hemorrhage point was. So it wasn't a preordained cutoff number. They found that for these small aneurysms, future hemorrhage of an incidental aneurysm was more common in patients that had a subarachnoid hemorrhage. So the group 2 patients were the ones that had presented with a subarachnoid hemorrhage from a different aneurysm, the group 1 where it was just a purely incidental aneurysm. And for these small aneurysms, they saw that there was a difference. But whether that's statistical noise or not, I really am not confident. They found that in the posterior circulation, and again, they're the ones who moved the PCOM aneurysms into the posterior circulation. Nobody ever thought of it that way before, but it was just kind of manipulating the numbers. They found that there was over a 5-year, in patients who had not had a prior hemorrhage, 2.5%, so roughly 0.5% per year for a small PCOM aneurysm, and a little higher if there'd been a prior hemorrhage. For the larger aneurysms, though, 7 to 12, 13 to 24, and 25, that didn't seem to matter. The size of the aneurysm seemed to overwhelm that little bit of increased risk if you'd had a prior hemorrhage. And as you go up in size, you see that the 5-year risk of hemorrhage really goes up dramatically. So when you get to giant aneurysms, it really doesn't matter if it's in the anterior circulation or posterior circulation. You've got a 40-50% chance, essentially 10% per year chance for a giant aneurysm to rupture. And then somewhere in the middle for these large aneurysms, 13 to 24, and still a fairly high number for the 7 to 12s. Anterior circulation, that's again 0.5% per year. This is 3% per year for a PCOM that's 7 millimeters. So that's not an insignificant risk for something that can be treated safely. Other studies and meta-analyses. This meta-analysis is actually fairly polluted by the ISUIA data in it, so it's overly influenced. And this meta-analysis suggested a 0.4% per year hemorrhage rate for aneurysm less than 7. And I think that the way I think about this is that this is really the absolute minimum risk, because I think ISUIA, because of the patient selection, really minimizes the risk of hemorrhage because the aneurysms were selected for non-treatment. Admittedly, I don't think the numbers are 10 times the ISUIA numbers, but I think the real-world numbers probably are somewhat higher than the ISUIA or even this meta-analysis, again, because of the reliance upon the ISUIA data. But this meta-analysis did point out some additional sort of risk factors for hemorrhage: age over 60, relative risk of 2 females, again, getting the short end of the deal here, increased risk compared to males. And again, that Japanese and Finnish descent coming up as being a problem there. So you might want to get your 23andMe analysis done. Additionally, symptomatic, we've already talked about, diameters greater than 5 millimeters, and the posterior circulation coming out as all being increased relative risk of more than double. Another more recent study from the unruptured cerebral aneurysm study in Japan looked at almost 7,000 patients, followed them for a fairly short period of time, but came up with an annual rupture rate of essentially 1% per year for all incidental aneurysms. Again, the hemorrhage rate probably higher in Japanese than in North American populations, but still a number that seems more sort of consistent with what you see. Like so many other trials, they found that overwhelmingly the size of the aneurysm was important, so that the 3 and 4 millimeter aneurysms had about 1/3% per year. 5 millimeter aneurysms about 0.5%, and then it starts going up fairly quickly. The 7 to 9, 1.7, and you get up to that giant aneurysms. Again, you're in that very high rate of aneurysm rupture for the giant aneurysms. Like other studies, the Japanese studies suggested that anterior and posterior communicating artery aneurysms had a relative risk of about double. Daughter sac was a feature that was, again, raised the relative risk, all things that we sort of intuitively have known and believed for years and took into consideration when we didn't treat those patients that we put into ISUIA. Growth on imaging, I mentioned earlier just a little bit. There was a study in Journal of Neurosurgery in 2012 showing an 18.5% annual rupture rate for aneurysms that were documented as growing. I don't know how long they followed those aneurysms after they documented they were growing. That's something that I would be very nervous to do. And in fact, Villablanca's trial from 2013 looked at the same thing, found an 18% rate of aneurysm growth on aneurysms that were followed. And that number to me is really high. I follow a fair number of aneurysms, and I don't think I see that many that grow. But they found a 2.4% per annual rupture rate in the aneurysms that grew. And that number is really artificially low because in California, they're not sitting on growing aneurysms. So they were treating most of them, but even despite treating most of the aneurysms they identified as growing, they still had a rupture rate that's 2 or 3 times what we think of as being the natural history. So there is pretty good evidence that growth is a real problem. So some of the recommendations that come out of that, the prior history of subarachnoid hemorrhage seems to be an independent risk factor. Enlarging aneurysms should be treated. Familial aneurysm should be treated more aggressively in patients and even at a smaller size than you might treat a sporadic aneurysm. Now we're going to kind of flip a little bit, and in the few minutes I have left, look more at the other side of the equation. Instead of what the risk is, what the natural history is, what the treatment risks are. That's the other part of the equation, and it's pretty disappointing when you actually try and look at what the treatment risk is, because it's really hard to get that number, and the data is really bad. And if you start with clipping, there are multiple single center retrospective series, and I know these are all well intended, but that's just really not acceptable in this day and age, I think, in terms of coming up with numbers that are credible. It's very hard to do self-adjudicated things objectively, and again, well intended, I'm sure, but so if you take all these multiple retrospective series and you do a meta-analysis of them, you still have really things that's not very reliable. But having said that, what's out there is from some of these meta-analyses of these many single center series is a mortality rate pushing around 2%, morbidity around 5%. If you start data mining, and it's sort of the rise of that really was around 2000, people started finding these databases and ways to get information. The National Inpatient Sample, NIS, is a big one that's been used a lot. The mortality range is somewhere 1% to 3.5%, morbidity 13 to 27%, so numbers considerably higher than what the other meta-analyses were. And these aggregate analyses of this are suggesting rates in the sort of 15% M&M. So you've got to start really looking at that natural history if that's the number that you believe is the significant morbidity and mortality. In the ISUIA, that was one thing that I think they did that was credible, was the prospective follow-up of the morbidity and mortality of aneurysms that did ultimately go on to be treated. And you see that's running at about numbers kind of in that ballpark of what we're saying, 2.3% mortality, 12% morbidity. I think those are credible numbers. And then the other part of any treatment is, it's not just do you do the treatment, does the treatment work? Does the treatment prevent hemorrhages? And that comes up more, of course, on the endovascular side. And everybody sort of assumes and believes that clipping is 100%. It's very good, but it's not 100%. And again, meta-analysis, these are self-reported, self-adjudicated trials mostly, so not great trials, but reporting around 92% completely occluded. That's a pretty good number, but it's not 100%. And around 4% neck remnant and 4% actual residual filling of the sac of the aneurysm. So very good, but not perfect by any stretch, and you do occasionally see recurrences and rehemorrhages in clipped aneurysms. One of the things that seems to really overwhelm the morbidity of surgical clipping are size and location. And if you look at a non-giant aneurysm in the anterior circulation with meta-analysis, you have very favorable numbers, morbidity, mortality numbers, in that sort of 1-2% range. You get into the posterior circulation, that number goes up quite a bit. in terms of the morbidity, roughly a 6-fold increase there. We get into giant aneurysms, again, a big jump even in the anterior circulation. You get the giant aneurysms in the posterior circulation, you're looking at 35-40% morbidity there. So, these are bad aneurysms, but you really sort of need to be very sober and sort of thinking about the indications for treatment, that kind of level of treatment risk in a patient who's asymptomatic. ISUIA showed some other relative risk factors, age over 50. Chris Ogilvie had a large series some years back looking at odds ratio, and he put it at about 1.03 per year of age. So age is clearly an important factor for open surgical clipping. And a prior cerebrovascular ischemic event, so TIA stroke, has a almost doubling of the procedural risk for clipping compared to patients who present completely intact. Hospital volume. Hospital volume has been looked at in a lot of studies. There's a little bit of controversy in some of the studies, but in general, most of the studies agree that volume matters, and the sort of minimum number that most of these studies end up with in terms of a little bit of a consensus is around 20 cases a year. So if you're an institution doing less than 20 cases a year, it's likely, not certain, but likely that the morbidity and mortality is going to be higher than the average. So that's open surgery. What about the endovascular? Not really that much better on the endovascular. There's still no really randomized prospective trial of looking purely at incidental aneurysms. There are a number of other trials where you can sort of get some of that data out of. But again, meta-analysis from cases done a little bit old, 2003 to 2008, showed satisfactory occlusion. So that means no filling of the actual sac of the aneurysm, but there may be a neck remnant in about 85%. Not a terrible number, but still 15% of aneurysms have filling of the sac of the aneurysm. Procedural complications, about 4.8%. And this is the real problem here. Aneurysm recurrence in about a quarter of patients, retreatment in about 10%, and rebleeding, fortunately, despite that, the recurrence and the residual aneurysms seems to be fairly low, but certainly higher than clipping, and you have to start looking at that number and make sure that number is really better than the natural history for a small aneurysm. ATENA was a study out of France. It was a prospective registry, looking at 649 patients with 1,100 aneurysms. That's almost 2 aneurysms per patient. But they tracked very nicely and had some independent adjudication on all unruptured aneurysms. They were unable to treat 4.3%, so a pretty high rate of success. But again, I'm assuming they're selecting aneurysms they think they can coil before they start. Complete occlusion, Ramon 1, if you're familiar with Ramon scale, around 60%, a little neck remnant in about 20%, but still, residual aneurysm filling in about 20%. And so that number is kind of for me, that's a little bit of a problem. They had adverse events in 15%. But actual neurological sequelae in only 5.4%, of which only 2.6% of patients had fatal or permanent neurological disability, and fatalities in 9. So you're looking at 3.5% neurological morbidity or mortality, which is a pretty low number. And 96% of patients who came in modified Rankin score 0 stayed modified Rankin score 0. So procedures clearly seems to be relatively safe. When you start looking at big databases for clipping versus coiling, Fred Barker was one of the early guys to start doing this in 2004, looking at that national inpatient database over almost 4,000 patients. And this is the odds ratio of an adverse outcome for coil versus clip favoring coiling. So actually, that's not right. This were both. It was age. It was odds ratio for patients younger than 65 favored coiling about two times the odds ratio and 4 times for the patients over 65. So again, that age impact making things considerably worse for open surgery in patients over 65. Randy Higashida looked at a different database, over 2,500 patients, adverse outcomes in clipping versus coiling, roughly double in clipping. You got to remember, these aren't randomized patients. They're not. The aneurysms may be different, so you have to take this with a significant grain of salt. You don't know that. You don't know whether the coiling had easier or tougher aneurysms. In 2010, another National Inpatient Service database scan, again about twice the adverse outcome rate in the CLIP patients. This one with a huge database, again about twice the number of adverse outcomes in the coiling base. And this most recent one, McDougall and the NAO groups, looking at this prospective database that I'm actually not that familiar with, but it's apparently a user pay database that's publicly available, around 5,000 patients. The difference with this one was they did propensity match the patients. So the patients, in terms of their morbidity, were better matched than some of the others. Still didn't match the aneurysms, but had an odds ratio if there was an ischemic complication, basically a stroke, of 3.4 times more frequent in the CLIP group than the coil group, and discharge to long-term care almost 5 times more likely for the CLIP versus the coiling. So none of these are randomized prospective trials. None of these are the quality of data that we really should have. But it is kind of a drumbeat of fairly consistent results that you have to start paying attention to. So at the end of all this, what do I do? How do I pick a patient? And for most of my career, it was really just kind of doing all this roughly in your head, and most importantly, I think, with a little bit of experience, having a sense of what you can do and what you feel you can safely do. When you look at an aneurysm and you feel ill, you should probably think twice about whether the aneurysm really needs to be treated, and you have to start respecting that nasty little voice. Not to the point of being timid, but it's unpleasant talking to families sometimes if things go sideways. So more recently, what I've started doing is using this unruptured intracranial aneurysm treatment score, and I've been encouraging the group here to use it. And this was something that Nima Eatman developed, and he got a group of, I think it was about 40 of us, to just start looking at a bunch of cases, talking about what we thought about when we treated cases, and he developed this Delphi consensus about what aneurysms we treat. And after that go around of sort of building a laundry list of things that we consider, he came up with a scorecard, and then he went and did another study and ran that scorecard by the people who'd helped develop it, and then an independent group. And what he found, what he created, was really kind of a consensus about which aneurysms we treat. And it's a little bit of a circular argument, I admit, because it doesn't necessarily mean you're treating aneurysms that are more likely to bleed, but it does tell you a little bit whether you're at least thinking the same way as the herd, whether that group think is a good thing or a bad thing. It does. You look at a patient, you talk to the patient, you fill out the scorecard, and you've already have your preconceived idea whether the patient should be treated or not. And then the scorecard sometimes says, yeah, it looks like everybody else would treat this aneurysm as well, or you're an outlier and you're being conservative when everybody else says that aneurysm should be treated, or vice versa. So the scorecard looks like this. It's in the publication that came out last year, and there's 3 domains on it. One is deals with sort of patient-specific data, one with aneurysms and one with treatment risk. And so to blow it up a little bit, the patient-specific things, all the typical things that I've been talking about this whole presentation. The age, so you score points, you just put it in the box here. So a 40-year-old gets a higher score because you're more likely to treat a younger patient than an old patient. 80-year-olds, they're going to score low on that. And then risk factors, you can be multiple. So if you have had a previous subarachnoid hemorrhage, you're going to get 4. If you happen to be Japanese, you're going to get 2. And if you're hypertensive, you're going to get 2. So if you're a hypertensive Japanese person with a previous hemorrhage, you're going to score 8 in that box. Symptomatic, yes or no. Again, it can be multiple. You can have cranial nerve deficits and have had, epilepsy. That'll give you 5. Other, this is a little bit of an opportunity to fudge a little bit. So the reduced quality of life due to fear, that'll get you some points. Or if somebody's, I don't care, then they're not going to score on that. And then life expectancy, does the patient have malignancy that's going to limit their life to less than 5 years? So comorbid conditions and life expectancy come into this, and then psychiatric disorders and coagulopathies and some other things. So you tally all those up, and you go on to the next section. And you look at the morphology of the aneurysm. Is it irregular? What's the aspect ratio? The size ratio relative to the parent artery, location, anterior versus posterior, and then a few others, and you score that up. And you add those all together, and that gives you a number that might be typically 10 or 12, and that is your score that favors treating the aneurysm. And then on the negative side, you look at the age. Again, there's more risk for older patients. So if you're operating on an 80-year-old, you're gonna get 5 points there. If it's a bigger aneurysm, it's going to be more difficult to treat, higher complication rate. You're going to get additional points there. And then there's a little bit of a fudge factor just for complexity. Is the aneurysm calcified? Is it, whatever feature it is? And there's a constant, because every treatment has some risk of 5. So you add these factors up, which are the negative against treatment, and you might end up with a score of, say, 10 to 7. And if the difference is more than 3, then there was a very high correlation with everybody in the herd advocating treatment. If there's a more than 3 the other way, everybody was conservative about it. And if it's in the middle, there just wasn't a correlation. People were all over the map. So it's not a gold standard, but I find it useful just to sort of make sure you're kind of at least in the mainstream, and also it forces you to ask sort of the questions which I often forget to ask if someone is Finnish, or some of the other things in there that ultimately actually could be important. So it is kind of interesting to go down the checklist, and I've found that some of the patients like it as well. They actually want to have a copy of their scorecard and stuff and shop it around. So in summary, to just kind of wrap up here, there are big fundamental gaps in what we know, both in the natural history, in our treatment risks, in our treatment efficacy, but we still have to make rational decisions with the information we have, and that's the real world.